Good morning, good afternoon, good evening, wherever you are, and welcome to the African Cancer Dialogues. The African Cancer Dialogues is a series of continental conversations where we try and look at new and emerging evidence and try and see how we're able to contextualize this to the African setting. We do look at recent international or regional conferences and try and see how these newer or emerging evidence for science actually applies to patient care in our setting. Today we'll be discussing the recently concluded American Society for Clinical Oncology meeting, and we're specifically looking at prostate cancers. Joining us today are Dr. Omolara Patirigun and Dr. Adewumi Alabi. Welcome. I'm going to let them briefly introduce themselves. Dr. Alabi?
Hello, everyone. Good afternoon, good morning, wherever you all are. I'm a radiation and clinical oncologist from the Lagos University Teaching Hospital in Lagos, Nigeria. I work special interests in prostate cancer. I'm a member of ASCO and AORTIC. I'm also a member of Advocacy, the Prostate Cancer Transatlantic Consortium. Thank you for having me on this cancer dialogue.
Thank you, Dr. Adewumi. Dr. Omolara?
Yes, good morning, everyone. My name is Omolara Patirigun. I'm a clinical and radiation oncologist. I work with the Lagos State University College of Medicine, as well as the teaching hospital. I'm the principal investigator for the Transatlantic Prostate Cancer Consortium in my site. I'm also a site co-PI on the ARETA clinical trial for breast cancer. I've been a member of AORTIC since 2009, and currently I'm serving on the AORTIC Research Committee. Thank you.
Okay, so welcome Adewumi and Omolara. I know you both had a chance to go through the prostate section of the ASCO meeting and attend some of the sessions there. I think my question to you both is maybe what are the interesting abstracts that you came across, and maybe you can tell us a little about why they were of particular interest to you. I will let Dr. Omolara go first.
Okay. So, I mean, it was really interesting going through those abstracts because, I mean, abstracts relating to prostate cancer for the AORTIC virtual meeting where, I mean, in hundreds. And so we've going through the abstracts. I mean, we decided to talk on three major abstracts that were presented. And we know that prostate cancer, I mean, is the commonest cancer in men worldwide. But in Africa, men of African descent, they tend to present at earlier ages. Their disease tends to be much more aggressive. And when they do come to the hospital, they come with metastatic disease, which is, I mean, mostly in stage 4. So for us, we decided to pick on those that were related to metastatic disease, castrate resistance. So we decided to focus on, I mean, those were the ones that really caught our attention of that with the non-metastatic castrate-resistant prostate cancer abstract and the hormone-sensitive prostate cancer abstract too. So those are the ones we're going to be discussing here because we know that most of our men would fall into these categories.
Okay. Thanks, Dr. Omolara. Dr. Adewumi, how common is castrate-resistant prostate cancer? Maybe just give us a scope of what you're seeing in your clinical practice.
So for us in Nigeria now, the incidence of late presentation generally for cancers is about 70 to 80%. And over half of the patients who you see on the regular clinic day in Nigeria have metastatic prostate cancers, hormone-resistant metastatic prostate cancer. So these are some of the reasons why we are challenged and we're encouraged that a lot of new evidences are coming out, which will also help us in curbing the morbidity and mortality that we have from prostate cancer. So this is why that's why this is exciting to us, so that we can look at something new and see if we can change our practice over here in Nigeria.
Yeah, no, I mean, I think Nigeria is probably representative of most of sub-Saharan Africa as well, because I mean, even in Kenya, we definitely tend to see quite a number of patients presenting or getting, one would say, diagnosed with fairly advanced cancers. Omolara, so maybe you can walk us through one of the abstracts that you thought was of interest. You said you had 3?
Yes. So basically, I mean, I think one of the 3 abstracts we identified focused on non-metastatic castrate-resistant prostate cancer. And basically, it was a meta-analysis that assessed the efficacy of androgen receptor antagonists, that's the 2nd generation, in combination with androgen deprivation therapy in non-metastatic castrate-resistant prostate cancer. A systematic review and meta-analysis of the Spartan trial, the PROSPER, as well as the ARAMIS. The PROSPER focused on enzalutamide, Spartan focused on apalutamide, ARAMIS focused on darolutamide. So all those 3 drugs are 2nd generation androgen antagonists, basically. And what these 3 trials did individually was to recruit men with PSA doubling time of less than 10 months, and also metastatic disease negative on conventional imaging like bone scans, CT scans, and MRI. And you know, the pooled analysis actually showed a statistically significant increase in favor of the androgen, the 2nd generation androgen antagonist. And generally, they concluded that the adding androgen receptor antagonists to ADT significantly prolongs metastasis-free survival in men with non-metastatic castrate-resistant prostate cancer. And so I decided to dig deeper and say, okay, how does it really apply to us in Africa? And basically what I did was I looked at the patient's characteristics of these patients that were recruited on these trials. And I saw that with the PROSPER, which focused on enzalutamide, no race was basically documented. It was just the region that was documented. The Spartan, it recruited just about 1.3% of men. And that group, that subgroup analysis was the only one that was not statistically significant, because we saw that men in that group that were on ADT alone had longer median survival than those men that were on the apalutamide plus ADT. So it brings a question about the power of the study. Is it because we had just about 1.3% of Blacks in that study? With regards to ARAMIS, they didn't also document on the race specifically, despite the fact that ARAMIS reported better side effects, because the darolutamide has reduced ability to cross the blood-brain barrier. So they came down with, less side effects. So, you know, it still brings us back to the African concept. We were not able to fully explore the benefits of this new therapies that, have been used in developed parts of the world. So it brings us to the fact that we really need to explore this. We know our men would have much more aggressive disease. They will present with metastatic disease, and they will present at younger ages. So we really need to have studies, including Black men, on these clinical trials in Africa, if we really want to explore the benefits of this new 2nd generation drugs, basically. So that was, basically.
Thank you so much. Dr. Adewumi, Omolara mentioned the fact that most of our patients tend to have more aggressive disease. And I think two questions to you. My understanding is that one would almost think about castration-resistant prostate cancer as almost like a continuum, as sort of like a sort of halfway between, I mean, it's just on your journey towards developing metastatic prostate cancer. Maybe if you could just comment on that. And then the second question I had is in terms of these sort of the androgen receptor antagonists, how common actually, or how available are they to the regular, say, patient in Nigeria?
So looking at it on the scale of the patients who eventually become castrate resistant and are metastatic, because there's just a thin line between patients who are not metastatic and those who are metastatic. Majority of the patients will even ab initio present with metastasis, whether they are castrate prostate, whether they are castrate sensitive or not, they would present with metastasis. So there's just a very thin line. That is from the clinical experience we have, that is the presentation we see them. Availability of androgen deprivation therapy for us here, it's fairly okay as compared to what we used to have in the past, but the challenges are still there. Patients pay out of pocket. We don't have good health insurance scheme. And so when patients have to pay out of pocket, it becomes challenging for them to maintain, to be on their drugs regularly. And so when they are not regular on their drugs, you would end up having more metastatic patients in the clinics. And so availability, yes, on a rough scale, yes, but the newer models or the newer drugs that we're having now, we don't have it as available as we want it. So, and affordability is also a challenge. So if we look at affordability, majority of the patients can't afford it. And so that's why we're also clamoring that clinical trials need to come to Africa so that we can have more of these drugs being used for the patients. And the more patients we have, the cheaper the drugs will become. Many of the targeted therapies that we have for other malignancies like breast and colorectal cancers, initially, ab initio, they were all expensive. They came in at a price where patients could not afford. But because of the advent of clinical trials like the AORTIC clinical trial studies which have come into our setting, the drugs have come in and patients appreciate what they're being given, and we're seeing better outcomes in the clinics. And so because of this, the prices have come down to a reasonable extent compared to when we started. And so this has become more affordable. So availability, yes, we have some of those drugs available, and affordability, which is a challenge, which is still what we're battling with, which we'll also overcome with time.
Thanks, Advocacy. Omolara, just sort of circling back around the question of affordability, how affordable are they? Because of course I sort of did a quick look just now on the cost of enzalutamide, for instance, and they're saying it costs about $90 per tablet and would cost a patient about 120,000 US, I mean, a year for treatment. Is that actually what's on the ground, or is that, I mean, how many people can actually afford that amount? And is that what you're currently seeing in Nigeria?
Yes, so thank you, Miriam. So most of our patients are, indigent patients. I mean, most of them.
Yeah.
And I mean, these are people who actually, they have this income that is, less than $1 a day, right? From the statistics that we have worldwide, I mean, less than $1 a day. And for those second line androgen deprivation drugs, they can come as high as 500,000 per month.
Wow.
That's Naira. And if you do
right. Oh, Naira, that would be around how many dollars?
That's about 1,200 per month.
Oh, wow. Okay.
Yes. Yes. Yeah. So for things like, I mean, our focus today is on enza, apalutamide, and darolutamide. For apalutamide, enza is also not even registered in Nigeria. So most of the time, but because we have better, I mean, relationships with places like India, Europe, then we could get these drugs imported when the patients need them. But for apalutamide, it's not yet registered in Nigeria, as well as darolutamide. Enzalutamide, we still get it sent in. It's not registered too, and it can come as high as $1,200 per month for the African patient. The same thing with, I mean, when abiraterone, that's just on the other flip side. When abiraterone first came in, it was almost maybe $2,500 per month, but now it's come down. I mean, I guess with the registration, Johnson & Johnson, a lot of advocacy, it's down to about $1,000 per month. And then we have, because it's off patency, the generic drugs have come in. And so you could get abiraterone as, I mean, up to about $500 in a month now for the African, I mean, for the Nigerian man. Some people can afford it, but I mean, this is way out of the reach of a lot of other men who have, who are diagnosed with prostate cancer, basically. So even if we have a route to make it available, affordability becomes a challenge. And that's why there's so much advocacy for coverage, national health insurance coverage for all these cancer drugs. We've been able to get a few of them on the national health insurance, but not everything. These are new second generation androgen receptor drugs. They're still coming in. And so the advocacy is still, I mean, ongoing with regards to those drugs.
Yeah, no, and I think you raise a good point around maybe also looking at the impact of increasing clinical trials, and maybe that would in some way try and mitigate in terms of try to improve access of these drugs to patients. And maybe the second bit that you're mentioning in terms of advocacy, whether it's from the oncology community and or you know, getting them to motivate for policy. You're talking about universal coverage, and these are perhaps even looking at the essential drug list. These may all go a long way towards improving access for patients. Adewumi, Amalora's talked about the PSA doubling time, and I'm going to sort of open up a can of worms and ask about PSA testing in Nigeria, because in Kenya, we're struggling as well, even just getting a basic PSA from lab to lab. So how comfortable are we when we talk about PSA doubling time, implying that we're doing PSA velocity for patients? How accessible, and what is the experience in Nigeria around PSA testing?
So in the African context, advocacy is now high. I'll admit that the rate of advocacy is high. We didn't have so much of advocacy before. People were not knowledgeable about what it means to do a regular PSA check. So, but now an average man knows he needs to do a PSA check at a certain age. Yes, we may still want to look at it that those in the rural areas may not have access to having PSA checked, but we have facilities in the urban areas where PSA is readily available for everybody to have a check. And affordability, it's quite affordable. It's affordable. People can walk in, have a check without so much hustle. They don't even need to see a physician before they enter into a diagnostic lab to have their PSA checked. we're able to also assess their PSA velocity, so we can look at the rate at their doubling time and look at other parameters that we want to assess with their PSAs. So the only challenge we have is that because of the African setting, the values of PSAs we get are quite alarming. So, and these are some of the things we would need to do some genetic studies on to see why the African descent individuals have PSAs that are high. PSAs running into 4,000, 5,000, into 5,000 are not common or regular PSAs with the average white. But here in this environment, we have a lot of people who have markedly elevated PSA values, and that will always pose a challenge in terms of treatment. Because when what's your choice of treatment? How do you want to choose what to start with when you have PSA values that are that high? And so this is a challenge. So, but having PSA doubling time in them, yes, this is also a challenge, and that's why we have a lot of metastatic cases in our setting here. And so these are things that we need to look at and see how we can work around them.
I think my follow-up question around that is because despite quite a number of these being available, what we see is quite a bit of heterogeneity in terms of testing from different labs. Same patient goes for a PSA in one lab and has a PSA of 20, comes back and goes to a different lab and has a PSA of 4. So how are there any, do you have similar concerns in Nigeria? And what are the attempts that you're doing with your pathology colleagues to sort of homogenize these? Omolara.
Okay, so with regards to the heterogeneity, as oncologists, we've been able to identify a few labs, that actually give us this reliable results. Some of them even have affiliates in South Africa. Some ship their samples out. So we've been able to identify a few of them. So, and those are the places we usually send our patients to. So whenever a patient presents and he brings in some form of PSA that doesn't tally, that has been done from some other lab out there that is not recognized, what we do is we do it at these labs. We've been able to identify 5 of them, especially in Lagos, that give us quite reliable, results. So we go with those labs as oncologists. That's how we have actually tried to, resolve that issue of the heterogeneous PSA results, basically. So that's, I don't know if that's, yes, that's how we've been able to overcome that challenge, because, it's actually a concern when you're treating, it's garbage in, garbage out. It's what the pathologist gives you that actually could actually mess up your treatment too. So we've been, that's basically even our histopathology results too. We send them to particular labs, labs that are in the general hospitals where we're sure the specialists are. Sometimes whenever we have histopathology reports that we're not sure of, we send for second opinion, right? Even imaging, yes. So when a patient comes to you and you can't, it's clinical pathologic features. If the clinical doesn't tally with the pathologic and it's looking funny, then we know the people to send to for second opinions. So that's how we have actually resolved that, the heterogeneous results that we see in our practice. Yes.
Yeah, and I think that's one of the things that we could probably try and see how to apply to, say, different contexts. If you're able to identify a group, as you're saying, of select labs or pathology services that are actually giving you consistently good results, and then have those act as referral centers maybe for the places that are handling your patients, and at least you have more consistency of care, and especially as far as your results are concerned. And I'm imagining especially in prostate, I mean, the PSA is kind of what you're hinging your treatment on.
Yes.
So it's critical to get it right the first time. Yeah. Adewumi, any other interesting abstracts that you came across?
Oh, yes. I also came across two abstracts. Dr. Fatiregu spoke about the abstract that was relating to the non-metastatic setting. And so I decided to look at the abstracts related to the metastatic setting. So I went through two abstracts, the ARCHIS trial, which was a phase 3 randomized clinical trial, which looked at the role, efficacy of enzalutamide and ADTs in metastatic hormone-sensitive prostate cancer patients. And the focus of this was to look at it in relation to patients who were on placebo and to see what the efficacy of these drugs will give. So I also looked at another abstract that looked at that was a systematic review on the treatment of metastatic castrate-sensitive prostate cancer patients. This focused on disease volume. By and large, both abstracts focused on high volume disease versus low volume disease. And the second abstract was basically to systematically analyze some abstracts that were published at conferences or poster presentations that looked at metastatic hormone-sensitive prostate cancers. And so this category of patients were assessed for their level of response and to look at disease progression. So the primary endpoint was to look at radiologic progression-free survival, while the secondary endpoints for the ARCHIS trial was to look at time to PSA, time to symptomatic skeletal related events, and also to look at the time to initiation of a new anti-neoplastic therapy. The results showed reviewed about 1,146 patients were used, and it was noteworthy to say that the category of patients who were looked at in these abstracts were from North and Latin America, from Asia, from Europe, and so we didn't really reflect people of the African descent in this trial. Probably we had some people of African descent, but this wasn't really pointed out, so we can't really generalize it for the African context because we know the disease is a bit different from what we've seen for us here. And the end result or the conclusion was that patients who had enzalutamide and ADT, as to patients who had placebo with ADT, the enzalutamide arm showed that they had improvements of their treatment regardless of the pattern of spread they had initially, and the progression-free survival was also prolonged for them. In comparison with the other study that looked at the role of androgen pathway inhibitors, enzalutamide, apalutamide, and chemotherapy. So for this, the first aim of the study was to see what was the initial choice for treatment for this category of patients and to see which of this treatment was more beneficial for them. And their target was to look at the volume of the disease. So both studies looked at volume of the disease. And in the African setting, we usually have high volume disease patients. And also to look at the initial agents the patient had received prior to treatment. So the methodology involved looking at studies, systematic reviews from Medline, MBase, Scopus. And so all these trials were combined, where all the studies or researches were combined together to see which patients actually benefited from the use of androgen pathway inhibitors. And from the study, we could see that patients who had androgen pathway inhibitors were better. The p-value was significantly, was statistically important, was improved compared to patients who had doxycycline. So for patients who had high volume disease, the patients with doxycycline had better benefits. Patients on chemotherapy had better benefits for those who had high volume disease. So on the long run, both groups had benefits from use of chemotherapy or androgen pathway inhibitors, but patients with high volume disease benefited more from androgen pathway inhibitors. And so that brings us to what we have in Africa, that if we're saying that our patients fall into the high volume category, so we should start looking at more advances in our treatment to see how we can get more clinical trials to come into Africa so that we can have these patients benefit from androgen pathway inhibitors. This will help us to increase or to improve the morbidity and the mortality, to help us to curb morbidity and mortality that we have from this disease. So by and large, the two studies focused on use of androgen pathway inhibitors and have demonstrated that we have improved quality of life, prolonged death from use of androgen pathway inhibitors.
Thanks, Dr. Dewumi. You raise a good point around high volume disease. Maybe Omolara, maybe you can, just for the oncologists who's not necessarily managing prostate on a routine basis, what do we mean by high volume disease? And the second question is, I mean, as much as like especially the study that was looking at docetaxel versus the androgen antagonist, I mean, we're saying at least for high volume disease, then chemotherapy did still show benefit. So my question to you is, despite us not necessarily having these novel agents, isn't the fact that we have access, hopefully, to some of the taxanes sort of some comfort in your practice? I just wanted to get your thoughts on that.
Okay, yes, thank you, Marianne. I'll start with the first question. So high volume disease is defined as when you have presence of visceral metastasis or greater than 4 bone lesions, right? Greater than 4 sites whereby you have bony lesions. That's metastatic disease, either in the visceral or, either in the spine or in the, basically in the vertebrae. So that's high volume disease as by definition. So anything lower than that would be low volume disease. So you have presence of visceral metastasis, and then you have these bony lesions, greater than 4 of them, scattered around. So for, with regards to the use of agents like docetaxel, I know that other studies have also explored that in hormone-sensitive metastatic disease, trials like the Stampede trial, the Latitude. So it kind of provides some form of comfort for us. So if a patient comes in and the patient presents with hormone-sensitive metastatic prostate cancer, we can definitely offer docetaxel. The taxanes are cheaper, basically. So you could get docetaxel for about, about $150 per cycle in Nigeria. So it kind of offers us that other option. So if the patient isn't able to afford the androgen deprivation therapies, then we can definitely fall back on the docetaxel if patient has good performance status, right? Basically, and as well as, if the patient is fit enough to actually go on chemotherapy, basically. So I agree with you. It actually provides some form of comfort to us as clinicians and as a second option of treatment. Yes.
Thanks, Omolara. Adewumi, just going back to the taxane story, we've talked about Lagos, but how accessible are these drugs, for instance, in the rest of Nigeria, the taxanes? Because sometimes we also have a few problems accessing them intermittently. And then how are you managing your skeletal meds for these patients?
So for the patients who want to, who require to take taxanes, who are required to take taxanes, availability is not a problem. Relatively, taxanes are available. So the challenge with taxanes is that we have a lot of generics in the market, which are affordable, which sometimes you can't really attest to the authenticity of the drug, or you can't say how efficacious the drug will be, the efficacy. Sometimes you can't really talk about that. So, but taxanes are relatively available. We have branded ones as well. Branded are more expensive, and so that becomes a drug of choice for people who can afford it. Because remember, I said our patients pay out of pocket, majority of them. By and large, the National Health Insurance Scheme has started putting some of these chemotherapeutic agents on the list. So some patients who have access, who are government workers, who have access to the NHIS, can actually get it from there. So the drugs are available. I don't think we have a problem with taxanes. So affordability is a bit of a challenge. It's still expensive, but we have a lot of generics which the patients can also use. So, your second question?
I was asking about your management of skeletal meds.
Skeletal events. Yeah, so when patients have skeletal metastasis, we prioritize to manage where there's pain. So most often they come with pain at the affected areas, or we also look at areas where we are thinking of imminent fractures, where we think the patient may eventually have a fracture with the way the bone is looking. And so we offer them palliative radiotherapy. Radiotherapy is still a big challenge in the African context. Very few countries have access to radiotherapy. Even in Nigeria, radiotherapy machines are very few compared to the recommended IAEA standard for the number of people who should be able to access each radiotherapy services. So we are not near that at all. So radiotherapy services are few. Some of those patients actually do well even on chemotherapy. Some of them who are not symptomatic, who don't have pain, and when you administer chemotherapy to them, to those patients, it strengthens their bones and you no longer see the metastasis anymore. And some patients will have to be on use of bisphosphonates, will have to be on bisphosphonates for an average of 1 year. So this is a monthly injection which is administered to them to help to strengthen their bone and to reduce further disease progression in those affected bony areas. So that's basically how we manage skeletal metastasis.
I think, thanks Adewumi. Omolara, how is the access, especially if you're having acute cord syndromes and that kind of thing? Because what again tends to typically happen as well in East Africa is because we have very few radiotherapy services, and because of the waiting times and stuff, are you able to get your patients through quickly, or what's your experience like?
So I think for us at the radiotherapy center, oncological emergencies are of top priority. So when a patient comes in, with either bleeding or bone metastasis, with imminent fracture. I mean, they could even be treated either the same day or the next day. That wasn't the initial, that wasn't the initial experience. But now because we work in the urban center and radiotherapy is just our patients are we can refer our patients as soon as and as fast as possible to these centers to get treated for any form of oncological emergency. But in the past, that wasn't the picture. But now we have, at Lutz alone, we have about 3 radiotherapy machines, then variant radiotherapy machines. There's one at the core hospital. That's like 4 machines just in Lagos alone. In the past, we had just 2. And we have about 2 also in Abuja. So yes, there's still a great need with regards to radiotherapy machines in Nigeria. Now we have better access to radiotherapy for urgent and oncological emergencies. We have more machines now in Lagos. At least speaking for the urban setting like Lagos, patients can easily access. So, and also biphosphonates too, they are available just like the generics that Dr. Alabi mentioned. But the only downside is the cost of assessing this emergency treatment. Patients who are able to afford it, of course, it's available. But now affordability is another challenge, right? So for those group of patients, there might now be some form of challenge with that because they have to rally around the whole family members and all that to get access to radiotherapy. And you know that most of the time before the patient even gets to the radiotherapy center or while the patient is on radiotherapy, we offer supportive medications like dexamethasone. So we offer that, then the patient gets the money and then goes to the radiotherapy center for his palliative treatment, basically.
Okay. Yeah, no, as you said, there's definitely a need to expand the access to all these services. But I think it's good in the sense that, as you said, there is early recognition and speed such that these patients and the oncological emergencies are treated appropriately. Of course, that's in Lagos. The question is, what's happening in the rest of the country?
Yeah. Yeah, I think it will be much more challenging for people in other parts of the country that especially don't have access to radiotherapy, and so I guess the surgical intervention might now have to come in areas like that, whereby you have things like laminectomies, in areas that you don't have access to radiotherapy, possibly. But in Lagos, that's where we practice, and it's easier to speak to those issues with regards to Lagos itself. It's more challenging in those rural areas to get access to radiotherapy. That still brings us to the need for more centers opening up in different parts of the country and even in Africa generally. Yeah.
You did touch briefly on surgery, and of course I automatically perked up as a surgeon, but I think Adewumi, in terms of androgen deprivation and those kind of options, how frequently are you sort of recommending or at least offering patients things like subcapsular orchidectomies just as a way of controlling their disease, or is it something that's coming out of favor with the dropping cost of medication?
So for patients going in for surgeries, usually when they're with the surgeons, some of them are given that option, because if you look at the cost of orchidectomy in Nigeria costs about roughly $200. And if you look at them having to go for the use of ADTs, let's say even the bicalutamide, if they have to be on bicalutamide go for roughly of say $100 monthly, and then they're going to take it for a longer period. And so if you give patients that options, many of them would want to go for orchidectomy. So, but we also have to remember that prostate cancer is also common in the younger age groups. And so when they remember the side effects, or when you take them through the side effects of what having orchidectomy is going to cost them, so some of them would decline having to go for orchidectomy. So even the elderly ones, you find some elderly patients who will also decline orchidectomy because of the side effect. And so in our setting here, orchidectomy is, yes, we have a lot of patients who take that option because of finance, because of costs. And I can say that it also helps to reduce their disease burden. So when they've done orchidectomy, their disease burden is also reduced. So we have quite a lot of patients who choose the option of orchidectomy.
Adewumi had mentioned that some patients decline orchidectomy just because of the side effects. But what I was asking is how culturally acceptable is orchidectomy? In some areas of East Africa, we have a lot of resistance because people believe from a cultural or spiritual perspective that they need to be intact to sort of, enter the kingdom of heaven. So we have a lot of challenges in terms of trying to bridge those barriers for patients. And I was wondering whether you have what your experience has been in Nigeria and West Africa, and whether this is culturally acceptable to many of your patients.
So, I mean, with our own, from my own experience, I think most of those patients, first of all, present to the urologist. Most of them are being diagnosed because they have their biopsies done there before we come into the picture. And most of the time, before these patients even come to you, they would have explored other options, when it comes to Nigeria. They would have tried the herbs, they would have tried whatever, in the community before coming to you. So when they come to you, I think that's one of the reasons why they even come in late, because sometimes when you probe and say, what have you been doing all this while, without presenting to the hospital, they would have gone round and round, to different places. So by the time they come to you, they've explored their cultural options, isn't it? So it's coming in second. They just want you to offer them what would get them back on their feet. And when it comes to things like orchidectomies, it really helps even patients in metastatic settings. Some of them, they already have the limb weakness and, metastasis to the spine. Once you get the orchidectomy could crash the PSA from 1,000 to 0, right? And they have this initial relief and all that. So when they come to you, they've explored other options. And that's what I meant by saying that culture now comes in second, because they've actually explored that option. They've presented to you because they want you to give them some magical option that's going to get them back on their feet, right? So for me, people take the option of orchidectomies too, especially the older ones. But for the younger ones, like I mentioned before, that still need the sexual functioning is still intact. They could do the Zoladex. Now comparing both sides, younger, older, those who can't afford Zoladex would go orchidectomy readily, basically. That's my own experience.
Okay, and Lisa says we're, I think, about 5 minutes away from getting cut off again, so we'll probably wind up a bit. But Adewumi, Omolara's talked a little about reluctance around patient disclosure. Patients have a reluctance to reveal their diagnosis, and perhaps more so we find, we sometimes find similar comparisons in cancers of reproductive origins like breast and cervical cancers. We notice that there's still quite a bit of stigma around a diagnosis. Is this something that you see in your practice in Nigeria? Of course, prostate cancer by default would have considerable implications around sexuality, perception of men. So what is your experience with that in terms of disclosure, and how do you try and maybe bridge the gap for patients?
So in our setting now, stigmatization is still a challenge, irrespective of what the cancer is, be it breast, be it colon. It's still a big issue because one, people are afraid that if they have to tell their friends, their family members, they will be deserted, they will be abandoned. And so because of that, they would rather keep silent or not tell anyone and just continue to manage, hoping that it will disappear, not knowing that the disease can only get worse. And so stigmatization is a big issue. Then the fear of the thought of it being a communicable disease. Many of them still think, oh, this is a disease that can affect their spouse, and they still ask you, you know, when the patient is gone, the spouse can come in to ask you, does he need to be afraid, or does she need to be afraid? Can she get the disease? So these issues are all bordered around ignorance, not so much of education has been done on what cancer is and how it can, and how cancer comes about. And so this is a big issue, stigmatization. So generally what we do is just to keep doing public enlightenment. We have a lot of survivorship forums now. We have so many advocacy groups now. We have a lot of support groups now. And so in these support groups, we try to impart knowledge. So we make them feel free when they are in such support groups, so that they can ask questions that really bothers them. And then that way we're able to help them to make them see the bigger picture of it. So when they have these support groups, so we invite survivors to come speak with them, to share their experiences, and that makes them feel more at home when they see that other people have been through their journey and have survived it. And it gives them also a sense of belonging, and it makes them see that there's no reason it's not a communicable disease that they need to be afraid of. And so these are just some of the things we put in place to help them overcome any form of stigmatization. But stigmatization is still very real among us, and we're trying to do a lot of public enlightenment, health awareness, so that they can know that it's nothing to be ashamed of, it's nothing to be afraid of.
No, thanks, Adewumi. You've just raised a very important point. Sorry, Omolara, you wanted to say something?
No, I just wanted to also kind of chip in a point there, you know, with regards to support groups. For us, we actually have a WhatsApp group that has about 150 cancer patients across board. So they could actually come together, and, you know, on the group, if there's they could actually post messages on the group, and you find them supporting each other, encouraging each other, even on the group. You find people who have completed their treatment coming there to share with others on the WhatsApp group. People who have challenges, whenever even a patient one of the survivor dies, you see them, they share it on the group, right? And they just, it's like a community, you know, apart from the focus group. We also have this WhatsApp group that actually helps. Then also like on the National Cancer Survivor Day, we had a doctor-patient survivor session whereby we had this robust discussion around cancer survivorship, that they're heroes and all that. So the doctors came into the Zoom room and the survivors too, as well as prostate cancer patients too, you know. So basically that's like something else we also do to like try to reduce the stigma in this part of the continent.
Yeah. And you both raised excellent sort of examples that I think would be very practical for other parts of Africa. You've talked about, you know, just getting the support groups where they're able to share and, you know, demystify cancers as well. And then simple things like the WhatsApp group where people are able to share. And I like the bit you said, Omolara, about community, because it's all about community. And as Adewumi was saying, if somebody's able to hear this story and say, hey, I actually went through this journey and I'm fine, then that slowly starts to reduce and demystify cancers. Yeah. I think in parting, my question to you both, and I'll start with you, Omolara, we've said, and Adewomi's also mentioned this, she said the majority of patients are getting diagnosed with advanced or metastatic cancers, prostate cancer specifically. My question to both of you is, how do we change the narrative around this?
Okay. For me, I think that we could change the narrative through quite a number of ways. One is, I mean, we have a lot of health education going on right now. Basically, we still need more of that. People still, it's a continuum. People still need to know about these conditions. We need to keep demystifying cancer, because if we keep demystifying it, then more people would come forward for treatment instead of exploring the options that is given to them in the community, like going to the herbalist, the traditional healers. So once we keep demystifying, and then we're able to bring them to actually come out and present, you know, based on the education that they have, what they know about these cancers, that should help us change the narrative. Then the other thing I would want to mention is research. We need a lot of research to understand the African cancers. Our men tend to come in earlier, they're more aggressive. So how do we modify this treatment, or are we actually offering them the best of care? Most of our treatments are adapted from clinical trials that were conducted in men of Caucasian descent, right? And we can see that the biology of the disease is different. So we need a lot of research, both epidemiological, behavioral, and clinical trials, to help us really define the characteristics of the African man's tumor, and also explore the treatment modalities that are available, you know, in order to improve survival in this group of patients. Because even when you see, there's some patients that, despite the fact that they are metastatic in developed countries, they still have access to this treatment, and they keep living, you know, they could live with metastasis for a very long period of time, because whatever the agent is, it was developed and targeted towards their own disease, you know, as compared to when we come back to Africa, when they come in metastatic disease. So we really need these clinical trials to help answer this question. What is the survival like? What else do we need to add? Is ADT better than this? We need to explore all those things. And the way we can actually answer those questions are through clinical trials. So we need more sites in Africa. When a new drug is coming out, more sites. We need more clinical trial sites in Africa to actually help us understand, you know, the effect of these therapeutic agents on our own patterns of cancers in Africa. So I think those 2 points are my major points, the major points I would like to add in changing the narrative. Thank you.
That's well said, Omolara, and we can't overemphasize the importance of all these different arms of research that would help to improve our understanding of disease. Adewumi, any thoughts around what we can do to shift the narrative?
Yes, I'll just add to what Dr. Omolara has said, that we need to improve on advocacy. We need to improve public enlightenment. We need to do more health awareness. Good enough, a lot of people are on social media now, so we can get out messages through social media for people to get enlightened on what prostate cancer is, on how to have a diagnosis made, on where they can have access to care. So having done this, this is not enough. This is not enough. After we've made diagnosis, after we've found this category of patients, we also need to make sure that they get good health care. So we need to do a lot of advocacy to the government to provide quality health care for those patients, quality, affordable, and available healthcare services. Services that they can easily have access to, not having to travel too far away distances to access these healthcare services. We need to engage the health insurance scheme to do more than they are doing now, so that all those drugs are available through the health insurance scheme and patients can have access to those drugs. If the drugs are available via the health insurance schemes, people will be encouraged to seek such options, to join the insurance scheme and have their health taken care of. So these are just some of the things we need to do so that we can reduce the number of patients who come to the clinics with metastatic disease, reduce the number of patients who come to the clinic with more morbidities than we would want. So these are just things that we need to start looking at. And just as she has said, one of the key things we also need to do is we need to do a lot of clinical research. We need to do a lot of clinical trials. We need to do research to see how we can actually achieve to use drugs that will work well for the African man. So these are some of the things that I feel we need to do.
No, thanks, Adewumi and Omolara. I think I appreciate the multi-pronged approach you're both suggesting, whether it's in terms of, at the grassroots level, educating the public, and as Adewumi, you were saying, using innovations like social media to push those messages across, right? And then, as Omolara was saying, research that sort of looks at a 360, both the behavioral, cultural, and again, pharmacological effects of some of these agents in our populations. And I think, and then as Adewumi was saying, I mean, just pushing policymakers in terms of improving access, definitely, because it's not enough to increase awareness. There's always the so what happens after. So it's definitely important as an oncological community to advocate for patients, even as far as policy levels are concerned. So, I mean, ladies, this has been a very, very interesting talk. We're going to have to wrap it up just now, but I wanted to see whether you have any parting shots, Omolara?
Yes, I know that cancer is not a death sentence, right? And if we continue to push those borders, we definitely would conquer cancer someday. And I'm hoping that it will be in our own generation. Thank you. Yeah.
That's well said. Any parting thoughts, Adewumi?
So I just want to say that cancer is real. Every individual, male, female, needs to know what is expected of them in terms of regular checks, regular examinations, regular checks at the right time, when they should do a mammogram, when they should do a PSA, So these are facts that we need to have at the tips of our fingers and remind ourselves from time to time so that we can reduce late presentations in our hospitals. The more early presentations we have, the more survival we will see. Thank you for having us on the program.
Yeah. No, thank you, Omolara and Adewumi. It's been an absolutely fun, just sort of going through and having this discussion with you. And I think in reflection, what I'm realizing, and Omolara, you sort of echoed this earlier. You're saying we're more similar than we think. Right? We sort of look at whether it's East Africa, West Africa, we're still dealing with issues of how are these medications affecting our patients. We're dealing with issues of stigma, disclosure. And so perhaps there's also an opportunity to do more collaborative work, even as we build this kind of research and this type of advocacy and this type of policy pushing. I mean, there's definitely roles for regional collaborations, perhaps in negotiating cost of care, cost of medication with pharma as a region rather than, say, an individual country. And that might help to leverage some of these to improve care for our patients. So I think I'm feeling super optimistic about where we're heading. And I think there's definitely lots of opportunities to sort of grow and develop this forward. And this is part of what the African Cancer Dialogues is about. Having a forum where we can exchange ideas, collaborate, share, iterate, go back to the drawing board, say what works, what doesn't, and keep sharing in order to improve our care for our patients. So once again, Dr. Omolara and Dr. Adewumi, thank you once again.
Yes.
And we're looking forward to more continued cancer dialogues.
Yes.
Thank you.
Yes, thank you too. Thank you, Miriam.
All right.